Welcome back to Oncology for the Inquisitive Mind, and it feels so good, Josh, to no longer be covering a conference that was finished a few months ago. And special welcome to those of you who are tuning in on YouTube. We've been uploading our episodes willy-nilly to our YouTube channel, but this is the first time we're actually going to put in an effort, as you can tell by the fact that I'm wearing a collared shirt and Josh is wearing clothes.
Yes, Michael, I missed the memo of the collared shirt, but I do have this cute little man on the top of mine. So, and it's clean. So these are two very positive points to start our episode.
So we are continuing at long last our Back to Basics episode. And the reason we say it's good to be back is because even though you will be hearing this in a different order, we have not recorded a Back to Basic episode since about October of 2025. So it does feel good. Feels doubly good because of our subject, which is my personal area of interest, and that is colon and rectal cancer. And the division between those two is very deliberate. So Josh, without further ado, I might launch into a bit of background and then into my study. That's the idea that I have for today.
That's a great idea, Michael. Why didn't you just launch it?
One of several very good ideas that will be happening in this episode. So a bit of background for colon and rectal cancer. When they're lobbed together, according to the World Health Organization GloboCan database, colorectal cancer is the third most common cancer in men and the second most common in women worldwide. However, even though they're often lumped together and in the metastatic setting, they're treated basically interchangeably, there are significant differences between colon and rectal cancer and between left and right colon cancer. This comes down to how they present. People are more likely to be symptomatic with left colon cancers and rectal cancers. Obviously, it's further down the alimentary tract, as they say, in the fancy anatomical spheres that we definitely don't frequent. There are differences in genomic trends, and there are differences in patterns of metastatic spread, particularly between colon and rectal cancer. And again, the fancy anatomists among our listeners and viewers will know all about the differences in lymphatic and vascular drainage. I mentioned the differences between left and right, and the definition of right and left colon cancer is actually quite debated because we can't agree where the colon stops being right and starts being left. Some people say it's at the midpoint of the transverse colon, some people say it's at the splenic flexure, and some people say it's anywhere in between. That is something that is a little bit difficult, but I think it is probably something that as we get more understanding of the genomic profiles of these different cancers, that will become a bit more clear. There are a number of things and other factors in the early stage of colon and rectal cancer. We're focusing on colon cancer in this episode that lend themselves to risk stratification, which of course increases or decreases the risk of overall recurrence. So the biggest one, as we will see in our couple of episodes on this subject, is TNM staging, and particularly T4 and to a lesser extent N2 disease. So T4 is the bogeyman in colon cancer. If you've got a T4 primary, it's generally thought that you have a high risk of things going poorly, high risk of recurrence, that sort of thing. And to illustrate this, the 3-year disease-free survival is 80% for T3, N1, or all other stages that aren't T4 or N2, but it's 60% for patients with either T4 or N2 disease. The tumour differentiation and grade, as with pretty much any cancer, higher rates of grade and more poorly differentiated disease is generally thought to be more aggressive. Cancers that produce mucin are thought to have a lower response rate to chemotherapy. And there's a bit of debate between, coming back to the right and left-sided debate, there's a bit of debate as to whether being right-sided in the early phase increases or decreases your risk of recurrence. And that, I think, largely comes down to whether the right-sided cancer in question is also deficient in MMR, which is a positive prognostic sign in the early phase. And the presence of lymphovascular and perineural invasion and molecular factors such as BRAF and KRAS mutations, and, as we'll see next episode, the presence or absence of circulating tumour DNA. But this is a pretty crude stratification system, Josh, and I know you've seen, and I've seen, and every oncologist listening has probably seen, patients who have quote-unquote low-risk disease. that comes back with a vengeance. And by the opposite point, there are patients who have very high risk disease that never comes back. And so a lot of work is currently going on to try and delineate patients who are higher risk of recurrence versus lower risk of recurrence beyond these factors.
I just keep thinking, because you've said factors a couple of times, and I keep reading this book to my daughter. It's like, these are the factors why I love tractors. So every time you say factors, I'm like, there are tractors involved. There are no tractors involved in this episode, but that was the idea, one of the many that came to my head.
Which is unfortunate. You've got to love a tractor.
And the premise of the story is the mum doesn't like the fact that the boy likes tractors. So I still don't understand that.
It sounds like there's something seriously wrong with that mum if she doesn't like tractors, quite frankly.
I am the one that digresses from the show. So, Michael, these are all really interesting things. And look, I guess this is the whole reason we're looking at ctDNA and we're looking at different ways to clarify left versus right side, because they are in effect a little bit rudimentary, because there is always a subset of patients who progress irrespective of treatment and irrespective of stage. And to be able to identify that and then tailor treatment is that holy grail.
Of course. I think that the relationship between these factors, even the advanced factors like ctDNA, is never 100%. But I think that the relationship in colon cancer, I don't know, it just seems a little bit less firm than perhaps other cancers. I feel like if you have a low breast cancer, it might be the fact that breast cancer management is far better delineated and the treatments work better. Anyway, there are many confounding factors to this. But let's crack on. The study that I'm going to talk about is the IDEAS collaboration. Not just a study. Actually, it's 6 studies. So the IDEAS collaboration was published in the New England Journal of Medicine all the way back in 2018, when I was but a lad and Josh was approaching retirement age. And prior to this study, the standard of care was a 5-FU-based chemotherapy plus oxaliplatin for stage 3 colon and rectal cancer. And this was pretty much established in the early 2000s with studies like NSABP C07 and the much catchier titled Mosaic trials from 2007 and 2009 respectively. And there are a number of other studies as well. However, as anyone who has given a platinum chemotherapy knows, there is a risk of chemotherapy-induced peripheral neuropathy. And unlike, say, with taxanes, there is a high risk of this peripheral neuropathy being permanent after completion of chemotherapy. The risk is cumulative, so the more platinum, in this case oxaliplatin, you give, the more likely the patient is to have problems. As a result, the very smart people behind this collaboration thought that perhaps if you gave less chemotherapy, you were less likely to have peripheral neuropathy. How about that for a leap of logic? So as I said, this was a collaboration between 6 trials, the CALGB SWOG 80702, the IDEA France, the SCOT trial, the ACHIEVE trial, the TOSCA trial, and the HORG trials. The total number of patients that were enrolled in these trials was more than 13,000, Josh. More than 13,000, which I think has got to be some sort of record. And for those of us on our YouTube channel, and we'll include links to the studies as we always do for those of you who are not listening or watching on YouTube, while each trial investigated the effect of the duration of adjuvant oxaliplatin-based therapy on disease-free survival, they weren't set up to be a collaboration. They weren't set up to be analysed together. So there are some differences. So several of the studies included stage 2 cancers, including TOSCA, and the HORG trials both included stage 2. And some of them included rectal cancers as well, because obviously the delineation between colon and rectal cancers has been a fairly recent development. The published report, they did sort of clear these out, as it were. So the published report only includes patients with stage 3 colon cancer. And it's important to note as well that some of the treatments involved did use adjuncts such as bevacizumab, as you can see at the bottom of this table, which is taken from the supplementary materials for the study. We love a supplementary material on this show. 5% of patients in the TOSCA study received bevacizumab. There were also some variations in the cohorts. So the rate of T4 tumours varied from 12% in TOSCA to almost 30% in SCOT. N2 tumours varied from 25 to 32%. CAPOX use was very variable, ranging from 0% in the SWOG trial to 75% in the ACHIEVE trial. I think my internet just cocked out, which is obviously worrying given my recent history. Overall, in the overall cohort, 40% of patients received CAPOX and 60% received FOLFOX. And the primary endpoint of this study was disease-free survival. And here we come to the results. The important thing, because this is a little bit of a difficult study to tease out, non-inferiority for the overall population was not confirmed. So it's that classic phrase, not non-inferior, 3 months of treatment versus 6 months of treatment, because that was the comparison. And the 3-year disease-free survival in the intention to treat population, 74.6 compared to 75.5%. However, they did do a lot of divvying up, a lot of teasing out of the data, because obviously lots of data was there to be teased out. So they had a pre-specified subgroup analysis. And the disease-free survival in the overall population, they're very close, but again, statistically speaking, they're not non-inferior. According to the subgroups, you can see things are pretty close across the ranges. So we have to look at the statistics. When you look at FOLFOX, 3 months was superior, 6 months, I should say, was superior than 3 months, with a p-value of 0.01 for superiority. However, for CAPOX, 3 months was equal to 6 months. So you can never give 3 months of FOLFOX adjuvantly. Let me put it this way, you can never plan to give 3 months of FOLFOX adjuvantly, but you can give 3 months of CAPOX. Exploratory analyses, as you can see, patients with low-risk tumours, so that's towards the right here. 3 months of CAPOX was thought to be non-inferior to 6 months. For high-risk tumours, there was a favourable comparison between 3 and 6 months of CAPOX, but this missed the non-inferiority margin. And we've got to go with that because the absolute differences are very, very small. FOLFOX didn't do so well in this study. Independent of the risk groups, independent of the patient factors and the tumour factors, 3 months of FOLFOX was always inferior to 6 months. Again, never plan for 3 months of FOLFOX. Understandably, the treatment adherence was lower in the 3 months versus 6 months group, 92.4 compared to 91.2%, 5FU versus CAPE, that's for 3 months, and then you go to 6 months and it was 81 and 78%. Unsurprisingly, though, there were lower rates of peripheral neuropathy, particularly grade 3 and 4, about, an 1/8 in the FOLFOX group and a 1/4 in the CAPOX group, 2 to 15 and 2 to 8%. There were statistically significant reductions in a whole bunch of other side effects, but I think that just comes with not having as much chemo. There was a final overall survival analysis, and this basically showed that the overall survival was pretty similar. And interestingly, the p-value for both non-inferiority and superiority was not statistically significant, with the exception of CAPOX, which was statistically significant for non-inferiority, not statistically significant for 6 months of superiority. So where do we go with this? Well, there's lots of other considerations, and we talked about the stratification factors, so you need to always tailor this to your patient. If you are FOLFOX inclined, as I am, I must say, I greatly prefer FOLFOX to CAPOX in a clinical setting. But if you are FOLFOX inclined, it's nice and easy. 6 months, all the time, every time. And if you need to stop because of toxicity, you obviously can. If you're CAPOX inclined, you can give 3 months for low-risk disease, but there are certain patients, so T4, N2, and cancers that are thought to be higher risk, that I would recommend, and I think the study would recommend more importantly, who cares what I think, you give 6 months to those higher risk patients. But if it's a lower risk and the classic is a T2 or T3 with an N1, you can definitely consider 3 months, and most patients would prefer less chemotherapy. Important to note, of course, that if we're lining these results up, this is only for stage 3 cancers, so stage 2s are out, and it's only for colon cancers, so your rectal cancers are out. But Josh, lots of very interesting stuff in this study. It is really the bedrock of adjuvant therapy. But you've got another very interesting study, another transformative study, some might say, which is for patients who have disease beyond a T4, beyond an N2, patients who are already metastasized.
That's right. And, with your idea meta-analysis, I remember reading it the first time when I started training and it just is a confusing study.
Yeah.
Don't know for anyone who's like, oh, that was really interesting. And it all sounds very clear because Michael said it. And then 10 seconds later, you go, I wish I had that written down. Well, guess what? There's slides now. So you can go on YouTube. But, and give us 5 stars if you like hearing us ramble.
And seeing us ramble as well.
That's it these days. I didn't do my hair that well, so I'm a little disappointed. But nevertheless, I've got my glasses on so I can see. So I'm going to look at the TransMET study. And the TransMET study is a good study. It's an interesting study. Like every study, in an ideal world, it'd probably be absolutely wonderful. But we don't live in an ideal world. So let's bring it back a notch and we'll go through the background. I'll go through the study design. I've got a couple of quick slides to show you just to give some visualization of this. And then we can talk about the conclusion. So TransMET was a liver transplantation plus chemotherapy versus chemotherapy alone in patients with permanently unresectable colorectal liver mets. TransMET. Met for metastases. Trans for, I don't know where the trans comes from.
I'm sure you could get it if you thought about it.
I probably could, but I'm tired. So, transverse?
Come on, Josh.
Oh, this is embarrassing. Transplant. There we go. Got it. Wow, that's wonderful. I'm so glad I made a fool of myself right now. So this is the result of this multi-center, open-label, prospective, randomized controlled trial. So the background is complete surgical resection plus systemic chemotherapy represents the best treatment for those with liver mets in the colorectal cancer space. And the 5-year survival rate's about 40%. And possible cure for metastatic colorectal cancer. Incredible. The issue is that greater than 30% of patients are considered to have initially resectable metastatic disease and suitable for upfront surgery, but the potential cure from surgery alone remains really poor. We want tumor downstaging. That's kind of the aim of this. You tumor downstage, kill the cancer cells, and then you have a complete resection in a response to chemotherapy. And that was found in prior studies to have better survival rates of 33%. They were retrospective series. So these were not prospective series, right? So, still pretty promising, and there's obviously data there to support it. They also found that response rates were quite high with chemo, like up to 80% in other randomized trials where doublet or triplet therapy were used. So we know that liver mets respond relatively well. We know that liver transplants work relatively well. What we didn't know at this point is whether if we do all this and we do a randomized controlled trial, will we still have the same outcome? There were studies from the 80s and 90s. So this was when I was an adult and Michael was still an embryo or an unknown embryo. He was a twinkle in his father and mother's eye, where the 5-year survival was only 18%. But there were lots of issues with this. So the chemotherapy was mostly fluorouracil. I don't think oxaliplatin had come along. The mosaic studies, which was the foundation and the building blocks of colorectal cancer, hadn't even read out or even been designed yet. And so here we come to, what is really quite a pivotal study for those who have this type of cancer. So I'll share you the study design and hopefully you guys can see it. The key eligibility criteria was really less than 65. You want that from a transplant perspective, good performance status, a low CEA, unresectable based on a panel, and an objective response rate to chemotherapy of at least 3 months and less than 3 lines of therapy. And you had to have good platelets and those sorts of things because, you don't really want to transplant someone who's going to just bleed out, right? The primary endpoint was overall survival. You can see my mouse just circling that there. The secondary endpoints, there were multiple of them. 3 are overall survival, progression-free survival, recurrence rates, and health-related. This is sort of what the endpoint is. So the study design, I'll just stop sharing for a second. Study design, your primary endpoint, 5-year overall survival, secondary endpoint, 3 OFS. That's what we want. So it was a prospective, multi-center randomized controlled trial. It was an open label with curative intent. Chemotherapy versus chemotherapy with liver resection. I feel that's all relatively easy to understand. And all those other things I sort of spoke about. So when we talk about the demographics, the majority were left-sided tumors. Most were T3 or T4 at original diagnosis. Majority of arms also had node-positive disease. And the timing of liver mets is about 196% respectively was synchronous in this cohort of patients. The number of liver mets mostly had more than 20, and then sort of 10 to 20. And then there were sort of very few that were sort of less than 10 in this cohort of patients. This is the TransMET study here, and you can just see sort of majority were male and those sorts of things. You can look at sort of the type of chemotherapy, so fluorouracil, oxaliplatin, irinotecan were there as well. But look, the interesting thing that we want to talk about is actually the outcomes, Michael, because I think that's what's going to define this practice. And then I'll talk about the limitations. So if you look at the primary outcomes and the intention to treat, it is actually really, really perfect. So we can actually see here. So the top red arm is the liver transplant and chemotherapy. And then if you look at the 5-year survival rate, it's a lot better. So the 5-year overall survival was 56.6% for liver transplantation plus chemotherapy and 12.6% for chemotherapy alone. I could have probably told you that without looking at this, but that's sort of where we're at. Because if you're going to have a response and then respond to the liver transplant, you're going to do much better than just chemotherapy ongoing. The median secondary progression-free survival in the liver transplant plus chemotherapy arm was 35.4 months with a 5-year secondary progression-free survival rate of 36.1%. At the last follow-up of the pre-protocol specified population, 42% of the patients in the liver transplant group plus chemotherapy group were alive without disease progression, and only one patient was alive in the chemotherapy arm. Quality of life, there was no difference between these arms either. So that's really, really, I guess, important. So overall, what we see that there is definitely a benefit for those that respond to chemotherapy who then go and have a liver transplant. Things that were not known in this timing of the study, the role of ctDNA, which would have been very interesting to see, because if you've got no ctDNA, can you then help stratify a little bit more? The other thing was also because there was a panel that sort of decided this. It wasn't just a clinician. So it was a big panel that sat and chose, you've got your low Oslo score, you've got your defined liver mets, you don't have other disease, you would respond well. So is there a selection bias of the cohort of patients in both arms, right? And if the cohort of patients in chemotherapy alone arm, you're not going to do as well just because you're on chemotherapy alone. So these are sort of unknown questions in the real world. And the other unknown question is also, how many livers do you have to go and transplant patients who have colorectal cancer, who are less than 65 when everyone else also needs a liver transplant?
It's a really impressive study. I think that they managed to even get it off the ground, to be honest. And, 400 odd patients enrolled. That's really impressive for such an intensive study, but you're absolutely right. This is the sort of thing that would be great if we had perfected 3D printing livers or growing them from stem cells, that sort of thing. And, you have a liver, everybody gets a liver.
Thank you, Oprah.
I didn't do the full Oprah though, thankfully to everyone who is listening and watching. But it is very difficult. It's important, and it comes back to what we were saying at the start. It's important for us to try and pick the patients who are going to have the best response, because transplanted organs are a precious resource. And until that changes, then this is something that's going to keep on having that sort of transplant board type approach. It is being done. I will say at the place where I'm working, there have been a couple of patients who have gone through the liver transplantation process and have done pretty well. But of course, there's always the risk that the minute you start putting someone on immunosuppression, that the cancer recurs, and not just recurs, but explodes. So it's a fraught process, but given the options for patients with this sort of disease, it's probably the best one if we can get there.
Exactly. Well, Michael, let's wrap it up because we're already over time for our usual recording. And what are we doing next week in the colorectal sphere?
So we're staying with early colon cancer. We are going from, I guess you could say, tried and true methods to stuff that is really exciting. So we've mentioned circulating tumor DNA a couple of times. We'll be looking at the pivotal study, Dynamic 2, headed by very much friend of the show, Professor Jeannie T. And we will also be looking at the seismic niche 2 that gave us the immortal Chalabi plot when it came to response. So look forward to seeing you and you seeing us. And also for those of you who are just listening, you can hear us again next time.
See you then. Bye.
Thank you for listening to this episode of Oncology for the Inquisitive Mind, produced by ADC Productions with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you liked this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts, and much more at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com. And if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.